Thanks very much for the kind introduction. I'd like to begin by expressing my gratitude to Jyoti and the other organizers of the ISCMPO, very beautifully crafted program. It's always a pleasure to be with known colleagues and friends. And although we have worked so hard, but unfortunately, as Girish and Ali mentioned, glioblastoma still remains one of the most lethal cancers in the body, a great formidable challenge. Our Indian data has been there for the last few years as well, primarily looking at different types of brains, different type of GBMs and high-grade gliomas. So it is hovering anywhere between 2 year survival between 25 to 30%. We have now 5 year survivals anywhere between around 10% or so. In a younger person, good resection, promoter methylated, it can be about 15 to 17% too. But largely, it still remains an incurable cancer with very, very few long-term cures. One of the important things in neuro-oncology in general, but also in gliomas in particular, is absolute need for a multidisciplinary meeting, the tumor boards, and these are very important because some of the patients are living longer. They may have issues, for example, to differentiate progression and pseudo-progression is very commonly discussed issue in the MDTs, but even in the lower grade gliomas, we have to differentiate and chalk out an evidence-based plan based on radiology and pathology and also the impact of molecular diagnostics in recent times. Although when I was studying maybe about 20, 25 years ago, that time, we always used to say surgery does not have, but there is now accumulating evidence, the need for surgical resection. Not only the enhancing component, which has been borne out by several studies, but also very fascinatingly, and this work was from MD Anderson, that it was the T2 weighted resection, the flare abnormality, so-called the infiltrative part of the glioma. And you have to have the balance between achieving a maximal safe resection, but also preserve the function. But fortunately, with a lot of adjuncts, including intraoperative MRIs, the neuronavigation protocols, functional MRIs, 5LA and fluorescein, and so on and so forth, it is very much possible now, even traditionally called deep-seated tumors, allocrine cortex, corpus callosum, thalamus, it's slightly an older gentleman or older person as well. So there is fortunately an increasing focus on achieving as much surgical resection, gross total resection as possible. And this has been borne out by a very recent JAMA Oncology meta-analysis, which also demonstrates a substantial improvement of gross total resection, and that nihilism from the neurosurgical point of view is beginning to, little bit get better over a period of time. Of course, you have to still individualize the surgical resection on an individual patient. There was a lot of emphasis on anti-angiogenic therapy, in particular bevacizumab and others, selengitide, for example. But unfortunately, as you know, the two very large randomized trials published in the New England Journal of Medicine did not show any survival advantage in newly diagnosed GBM, although there was improvement in the quality of life. There is a recent study in recurrent setting, though if you combine hypofractionated stereotactic radiotherapy, there was some improvement in survival. We introduced bevacizumab many, many years ago in TMH, and Dr. Patil and others have carried on it. They have also shown recently the safety and efficacy of the biosimilars in a recurrent setting. And also when there is a significant treatment change, it still remains a very good molecule. There have been also attempts of lateral thinking. For example, Tumor Treatment Fields, a randomized clinical trial led by Dr. Stoop, which was published 4 or 5 years ago using a treatment field on a helmet kind of a scenario, and it showed an improvement in survival and also had an improvement in the quality of life. And this has been borne by recent analysis as well. There are challenges in many parts of the world to use this technique, this Optune helmet, but nevertheless, this is also one of the things that can be done. Several years ago, Tejpal Gupta, my colleague, and some of us also looked at the subventricular zone as a glioma stem cell niche area as to whether that has any correlation with the gliomagenesis and improvement in survival. And there are 2 or 3 randomized trials going on at the moment in the world. We tried using BC vaccine, unfortunately has been a failure. We were very excited about an anti-EGFR V3 vaccine because 15 to 20% of the GBMs exhibited EGFR V3 mutation, and a vaccine was there based on a good quality phase 2 data. Eventually was tested in a phase 3 randomized trial in a large international setting. Unfortunately, did not show any survival, and again demonstrate how difficult this tumor is. However, there has been some attempt on IDH1 mutation. IDH is an increasingly important mutation. It's a gliomagenesis driver mutation gene. And although only about 10 to 15% of the GBMs have IDH mutation, but very strong evidence is building up, led by Michael Platten's group in Germany, where they are testing an IDH peptide vaccine. Initially, of course, in recurrent tumors, but eventually in a proportion of gliomas and glioblastomas. Hopefully, it will make some difference in this setting as well. This was just to show you a case, 2009 glioblastoma, who is still doing very well. It was re-excised, retreatment, and the most important point was this was one of the few glioblastomas which had IDH1 mutation. The new WHO 2021 classification, of course, now says that if you have IDH mutation in glioblastoma, you do not call it glioblastoma anymore. You call it astrocytoma grade 4, just to emphasize that they have better survival and better outcomes. So if you have an IDH mutant GBM, we don't call it GBM anymore, and we call it, and it can be anywhere between grade 2 to grade 4. We did the ISNO consensus guidelines a few years ago, and now we are looking at gearing up ourselves to form some guidelines for the 2021 classification. Also brings me to the point that there are several layers of glioblastomas which have been recently identified as well. This is a case, for example, in our practice, 42-year-old, which was a March 2016 GBM, right temporal, had surgery, had the usual radiation plus temozolomide. After about 4.5 years, had a recurrence. We re-excised, and this time we followed it with re-radiation with proton beam. But most important was that the histopathology was an epithelioid glioblastoma, which is characterized by a mutation in BRAF V600D gene. So this is a BRAF V600D positive or mutant type of glioblastoma. And there are two molecules which have been identified, both the BRAF inhibitors and the MEK inhibitors, using a dual combination of dafrabenib and trametinib. And along with bevacizumab, this lady is still doing very well now, about 7 years post diagnosis of a glioblastoma. So these are some of the cases that you will see more and more in your practice. These were two, again, very recent cases we saw in our practice. Unusual epithelioid, 9-year GBM, 6-year-old GBM, both had BRAF V600E positive, both were epithelioid GBMs, and therefore targeted therapies are very important. Vivek Subbiah from MD Anderson last year in AACR presented a fascinating abstract on this cohort of patients, and just a few days ago in Lancet Oncology, the so-called ROAR study was published by Patrick Wen and Vivek Subbiah as the lead authors. Essentially, what it shows was that irrespective of the pathology, in that sense, tissue agonist, but if they have a BRAF V600E, and 31 of these patients were glioblastoma patients, they had very good response rates with these molecules. Interestingly, the grade 3, of course, did much better. The median survival was 45 months as compared to 13 months in a recurrent setting. But most importantly, a younger cohort of patients, less than 40 years, they had a significantly better, this is a recurrent GBM setting of 45 months, which is very, very encouraging. And therefore, this has to be tested in a prospective, newly diagnosed settings as well. Finally, immunotherapy, a lot of emphasis, unfortunately, both the checkpoint inhibitors, and there is some data on even CAR T cell therapy, is largely disappointing because of many reasons, because of the immunogenetic potential of from gliomas and so on and so forth, which can be discussed in some other point. There is also some increasing evidence of what is called histone H3K27M, which is in diffuse midline gliomas. Now we call it H3K7 alteration. It is the brainstem gliomas, but they can be upgraded as glioblastomas. And there is some data on a molecule called ONC201, which is a DRDO agonist, and has shown some fascinating data both in children as well as in adults. Finally, there is also a glioblastoma which has been increasingly recognized, what is called diffuse hemispheric glioblastoma, which has a unique mutation called G34 mutation. And this is one of our own children treated in the Proton Cancer Center, which was histone G34 positive. And two recent publications, one in the Cell, another in Neuro-Oncology, they have demonstrated PDGFR and CDK4/6 mutations in them, and there is a lot of data now coming up, including targeted therapy in at least this cohort of patients. So there is some exciting time in glioblastomas from the systemic therapy point of view as well. Some data on ependymomas. And there is also some evidence that lymphopenia decreases overall survival in glioblastoma. So the recent studies using, for example, high precision techniques, even proton therapy, which can reduce the lymphopenia component, not only the temozolomide component, and is being tested in the BN001 in the NRG group, where proton versus photon technique will be compared in order to reduce the lymphopenia to improve the survival. Finally, I just wanted to tell you that in the current era, the virtual platforms are including in practice. I would just want to acknowledge the work that we did, led by Dr. Vijay Patil, which is a shadow study which demonstrated as a level 1 evidence that the virtual follow-up is as good, and it has connotation not only in the neuro-oncology space but also perhaps in other space. So with that, I thank you very much.